Good morning, everyone. Thank you for joining us today. I'm Terrence Henry. I'm the Executive Director of TAMEST, the Academy of Medicine, Engineering, and Science of Texas. We're glad that you could all be with us today for this conversation about the COVID-19 pandemic and where we are on modeling of the virus and testing of the virus in Texas. We're really excited to have all of you here today to convene on this very important and timely topic. Before we begin, I'll just kind of go over our schedule for the day and then tell you a little bit about our organization. We're going to have a 1-hour session today with 3 speakers. Our first speaker will be Professor Peter Hotez of Baylor College of Medicine, who is also doing double duty as our moderator today. And then we'll hear from Dr. Rebecca Fischer of Texas A&M University, and then Dr. Lauren Meyers from UT Austin. After each speaker, we're going to have a little bit of time for follow-up questions from the other speakers and panelists in the session. And then towards the latter half of the session, we'll have some Q&A. We've asked to have some questions submitted in advance, and we have a couple of those. If there are questions that you have during the session that you'd like to ask when we get to the Q&A, please use the Q&A box in Zoom, or you can raise your hand and we may call on you and unmute you at that time to ask a question. I know that many of you are familiar with TAMEST, but for those of you that are not, we are a nonprofit group that brings together the scientific research community in Texas. We were founded in 2004 by 2 Nobel laureates and then Senator Kay Bailey Hutchison. And our mission is to bring together the research community, foster collaboration, and to support science in Texas. To that end, we're starting this series of conversations on COVID-19, particularly from a Texas angle, and really excited to hear from our researchers today on what the science is telling us about this disease. With that, I'll turn it over to Professor Peter Hotez, who will be our first speaker today. Peter, thanks for joining us.
Well, thanks for having me. It's always an honor to do things with TAMEST. TAMEST, I think, is one of the very important organizations here in Texas. There's nothing quite like it. One that brings together all the members of the national academies, National Academy of Sciences, National Academy of Engineering, and of course, National Academy of Medicine together, who work and live in Texas. And people are often surprised how many National Academy members are actually in Texas, and what a powerhouse for science and engineering and medicine the state of Texas is. And I think, one of my take-home messages is going to be the opportunity for us to have a bigger role in responding to COVID-19. We've got enormous horsepower in the sciences and engineering and medicine, and let's tap it to really provide some leadership for the nation on how we can respond to COVID-19. So that's one of my messages. A second one, before I ask the others to speak, is to say overall we've done pretty well, I think, with COVID-19, certainly compared to other parts of the country like the Northeast in the New York area, which has been hit so hard and has had so many ICU admissions, or in Boston, where a lot of my family lives, my brother and sister and my mother, and also some of the West Coast and a few other cities. And I think one of the reasons that we did so well is we enacted social distancing measures pretty early on in the game. And in some of the models coming out of Mark Lipsich's group at Harvard School of Public Health has shown that there's a pretty good correlation between the number of ICU admissions, intensive care unit admissions in your community hospitals, and how long it took you to intervene. So in other words, if you look at what happened in New York City, probably transmission of COVID-19 began in early February and was allowed to go sort of unfettered until when they enacted social distancing. I think it was around March 22nd. So that 6 weeks of transmission fueled a pretty massive epidemic in New York that has now affected by some estimates, 20% of the population of New York City, and has resulted in thousands of ICU admissions and deaths. And I think what happened was when we saw what was happening in New York, here in Texas, we probably shut things down or enacted social distancing way ahead of before the virus had really picked up. And that few weeks of extra time, I think, made a huge difference. I think the big question before us now, one of the big questions is how do we move forward now that there's been a lot of pressure to open up the economy and to get people back to work and to restore some semblance of normal life. And I totally get it. My youngest son, Dan, works in the oil and gas industry, and he's watching the prices of oil and getting very upset and worried about his colleagues. And so I understand the urgency to open up the economy. The piece that I think would be worth exploring in this hour is how do we do this in a way that recognizes that it's just not a matter of the economic recovery, that we build the public health infrastructure that we need to sustain that economic recovery. Because my big worry is that things are going to sort of move along pretty well for the next few weeks. But then as we head into the summer and fall, we'll see a big uptick in the number of cases again. And the ICUs will start to fill up, especially in our urban centers in Houston, Dallas, and San Antonio, Austin, Fort Worth, elsewhere. And this will get people very worried about staying in the workplace, and we'll actually lose ground. And so it'd be worth exploring today about what we could do about that. And I'm especially interested to use this time to look at how we can better tap both TAMEST and all of our amazing engineers that we have here in the state of Texas. One of the reasons we moved here was for my son Dan to get the best engineering education he could, and I think he's done that. It's been extraordinary to see the engineers coming out of the oil and gas industry, out of NASA, the chemical industry. How can we mobilize them to work together to create a very unique solution for Texas that could then be applied to the US, whether it's an app-based system for surveillance or whether it's an app-based system for contact tracing or something else. I think we have an opportunity to employ, I don't want to employ literally, but to bring those, especially some of those young engineers to apply to helping us solve this problem. And with that, what I'd like to do is call on my two amazing colleagues, Rebecca Fischer and Lauren Ancel Meyers, and I'll ask them to briefly introduce themselves. I'm a professor at Baylor College of Medicine and Texas Children's Hospital, where I co-direct a vaccine center and also the dean of the National School of Tropical Medicine. So I'll have Dr. Fischer go first and then Dr. Ancel Meyers. So please say a few words about yourself and a few opening remarks.
Sure. I'm Rebecca Fischer. I'm an assistant professor of epidemiology and infectious diseases at the Texas A&M University School of Public Health in the Department of Epidemiology and Biostatistics. My background and training has primarily focused on epidemiologic analysis and describing trends and of diseases in the population, particularly infectious diseases, but also other tropical diseases.
You want to make a few opening remarks on some of the big picture you're thinking about?
Sure. I have a few slides to share just to orient the group to the situation where we are here in Texas. So I'll share those, if that's okay.
Okay.
I assume that you guys will alert me if if I've got a slide sharing problem. So I just wanted to, as we go into this conversation, orient everybody to where we are in Texas, what the numbers mean. And I know that we have a diverse audience here. So just to describe a little bit of the epidemiologic scenario here in Texas. So this data that I'm showing you is publicly available data and then just compiled by myself and our team at Texas A&M. So as of yesterday's reporting, we had in Texas 43,000 cases of COVID reported to the Department of State Health Services. So it's important to note that these are reported cases, so they're laboratory confirmed in Texas. We think largely they represent symptomatic cases and probably the moderately to severe cases, and largely do not reflect asymptomatic or mild cases that are in the population, and don't reflect disease among individuals that have barriers to seeking care or have perceived barriers to seeking diagnostic testing. And then just about 1,200 deaths in the state. So that gives us a case fatality of 3.8%. And that is, so the number of individuals who experience a fatal outcome out of the total number of reported cases, again, with all the caveats to reporting and detection. This also relies on deaths to be attributed to COVID. So individuals who may die at home or again, who have not been tested for any reason would not be counted in these numbers. And this number, just for your information, this is we like to talk about case fatality in using a delay. So the individuals that experienced fatal outcomes yesterday, we consider them out of the cases that occurred 10 days prior. So in that sense, it takes individuals some time to progress through their illness. So in this figure, these red caps represent the total number of deaths and the blue bars represent the growing cumulative number of cases. So you can see here that we indeed have a small percentage of 3.8% of individuals that are suffering fatal outcomes. Now, when we talk about the recoveries, this number is quite frustrating in the media because it takes sort of a long time for somebody to be counted as a recovery, and there are varying clinical criteria and diagnostic criteria for that. But you can think of all of the individuals represented in these blue bars as individuals who will ultimately recover. And I think that's probably a more useful frame of reference than thinking about the numbers today that have been contacted and followed up and confirmed to be symptom-free for so many days or tested negative, and sort of a really convoluted process. And so just to show you where Texas lands in comparison to other states, so this is just a graphic that shows the per population, per capita number of infections of COVID for each state. And so this is a time trend, so over time from the first day the state reported a case. And what we see here, New York State. So this is why we've seen this in the news, but who's following close behind in terms of growing number of individuals per capita affected is New Jersey. And so some useful pieces of information are the slope of this line, as well as the height of this line, indicating a higher per capita infection rate. So here I've kind of made Texas this orange knobby number. And as Peter said, we have fared well, and we seem to be faring quite well. Of course, every state started out with a sort of flat start. So we want to be careful moving forward that we do everything we can not to shoot up and follow the way of sort of these Northeast states that we're seeing increase. So the other image that we see a lot in the media and that's really relevant is the per day number of cases that are reported. And I've just mapped this out here for the state of Texas. And so this is the curve, sort of, if you can sort of blur your eyes and imagine a smooth curve over here, this is the curve that we talk about when we talk about flattening the curve. When is the peak going to happen? When is it going to be over? And so looking at these daily number of reports, we actually keep seeing an increase here with just yesterday, almost 1,600 cases reported across the state of Texas. Now we have peaks and valleys, and some of that is artifact of reporting and diagnostic delays that are represented here. So just keep in mind, blur your eyes and watch the trajectory and see where we go from here. Importantly, as we know, May 1st marks sort of a landmark event in our state, and given what we know about the disease taking some time to detect, as well as taking some time to be reported, what happened in May 1st or around May 1st may not be evidenced yet, and we may just be starting to see signs of those creeping out. So some of Texas vulnerable populations, of course, what we're hearing in the news, elderly and other residents in nursing care facilities and other long-term care, incarcerated individuals, immigrants either in high density communities or in detention facilities, transient populations, shelter populations, those without homes or living in streets or camps, and really anybody living in high density living situations. And so in the nursing homes, this is an article just from the New York Times showing across the United States nursing homes or residents where at least one resident tested positive. And you can see it, in Texas here, we are splattered with cases across the state, but the number of facilities that we have is 374 and reported cases being 1,332. Overall in the United States, a third of the deaths that we are seeing have been attributed to fatalities among nursing home residents. But in Texas, that number actually is 43%. So we are a bit ahead of the national average. And then recently in our media, we've seen a lot about our detention facilities for immigrants and how these COVID is propagating within those communities. And as well, another concern for these facilities is that they spread into the nearby communities. And sometimes these are located just as prisons and jails may be located in communities that are sort of set apart and may not have immediate resources and access to the care that they need with coronavirus. So just to quickly tell you about Brazos Valley, where we have 7 counties where they're mostly rural and small populations around the Texas A&M campus, we see that our per population attack rate here in orange has grown and mirrored quite closely the attack rate of Texas. So Texas shown in blue. Over time, and both approaching about 15 individuals per 10,000 residents. But what we see here are these red caps that are quite tall. So our case fatality in Brazos Valley actually is about 11%. And that reflects some of the clusters that we have seen in our valley among particularly nursing homes and some elderly populations. So I just wanted to present this piece of information. As we think about the Texas data, there's so much heterogeneity, and we have a lot of populations that are really vulnerable and have limited access to care, maybe at risk for severe disease and fatality. So moving forward, when we talk about solutions across Texas, we really need to have some tools and probably multiple tools that can be applied to a just super heterogeneous population. So I will stop there and turn it over to Lauren.
Well, great. Thank you so much. So before we ask questions, I'd like to hear from our next panelist if we can, and please introduce yourself, Dr. Meyers.
Hi, I'm Dr. Lauren Ancel Meyers, and I'm really honored to be in front of this distinguished audience, and also to once again be with Dr. Fischer on Zoom, who I met earlier in this during this threat on Zoom, and Dr. Hotez, who I have admired from afar for many, many years. So thank you for having me here today. I'm going to share. Thank you. I'm going to share my screen and go through a few slides. I've essentially prepared a whirlwind tour of some of the decision support and forecasting efforts that we have been undertaking over the last 3 months. So let me just start by saying that I've been working, I'm a mathematical modeler. I'm at the University of Texas at Austin. I'm in both the biology department and a statistics department, and I'm the founding director of the newly formed UT COVID-19 Modeling Consortium. But I've been working on modeling epidemics and pandemics my entire career, going back to 2000, and I've been working with the state of Texas, the CDC, other public health agencies at multiple different scales in trying to build tools, build models that help us to understand how epidemics and pandemics emerge and how we can use our limited public health resources to slow spread and save lives. And what you see here is a video of a simulator of a pandemic that we built in the aftermath of the H1N1 pandemic for the state of Texas. It's part of a decision support toolkit that's online. This is an image from an ongoing project to build very similar decision support tools for the CDC. The fact that we've been building these tools for over a decade meant that we were really poised when COVID-19 started spreading to very rapidly adapt our models to provide decision support. And we've been doing so. We've been working on an almost daily basis with the city of Austin And we also regularly respond to requests from the CDC and White House Coronavirus Task Force. We've also been doing our best to get, to inform the public, to educate them about what we can and can't know, or can't project from our models, and how policies and individual decisions might impact the risk in our communities in the weeks and the months ahead. So I'm gonna run through 3 different areas in which we've been focusing our efforts. The first is really, particularly early on, but still today, just trying to make sense of the data, trying to get a handle on how this virus spreads, how severe it is, how heterogeneous it is in terms of who it's making sick, who's ending up in the hospital, who's dying, et cetera. Some of our very first work in the, really in the days after we all heard about this new anomalous virus in Wuhan, we tracked down whatever data we could on cases in China. Also, we got our hands on mobility data, cell phone GPS traces from tens of millions of people in China to try to figure out how fast it was spreading, how far it had spread. And the kinds of things we found early on were that this virus was spreading much further and much faster than we had originally understood and hoped. So for example, one of our early studies suggested that by the time that Wuhan locked down on January 23rd, they had reported 425 cases, and we estimated, based on the early mobility data and early case data, that there were probably well over 10,000 cases in Wuhan by the time of that lockdown, and it had probably already spread to many other cities across China and the US, and now that's all been validated by the outbreaks that have emerged. We also got looking at the early case data, published one of the very first studies that showed that this coronavirus was spreading much more quickly and much more silently than SARS. And at first pass, we thought that this might look like SARS. And so our studies showed that the average serial interval between me developing symptoms and someone else who I infected developing symptoms was only about 4 days compared to SARS 8-day serial interval, and that people were certainly contagious before they ever felt symptoms. And that is what has made it so difficult to contain. And Dr. Hotez introduced this session by mentioning that perhaps the discrepancy or the differences we're seeing between what's happening in the New York, New Jersey area and other parts of the country had to do with the timing of intervention. And that some of the very earliest data out of China also showed us that even a 1-day delay in one of the cities outside of Wuhan, 1-day delay in enacting measures could translate to several days delay in their ability to contain even a small outbreak. So that the early data was very telling. Now I want to turn my attention to another major focus of our consortium, which is building models to forecast the spread and particularly the mortality due to COVID-19 across the United States. We have an online forecasting model that will forecast mortality at the US level for all 50 states and for a few, around 100 metropolitan areas for which we have enough mortality data. We project 3 weeks out what the mortality will be, as well as communicates the uncertainty in our model. What is the probability that we've already passed our peak or we will in the next 2 weeks? And what's driving these forecasts, what's under the hood, is a daily look at mobility data from the cell phones of tens of millions of people in the United States. This is the kind of data that we're looking at. So this actually, there's 2 lines in each of these graphs, and there are lines corresponding to the city, the Austin metro area and the whole state of Texas. Texas is dashed. And what you can see at the top is what proportion of the day people's cell phones are at home. People are staying at home. So you can see that sometime in sort of mid-March, people started spending a whole lot more time at home. And then in mid-April, they started going out a bit more. And these are the number of trips per day to places like bars, grocery stores, doctor's offices, parks, restaurants, schools. You can see the converse trend that people stopped going places starting around the time schools were closed in Texas and in Austin, really dropping when the stay-home orders were in place. And then it's been rebounding ever since around mid-April. And our forecast is our forecasting model is one of a growing number of models that have been built by leading research teams around the world. The CDC and many public health agencies and other decision makers are taking a very sensible, what we call ensemble forecasting approach, where they don't believe any one model, but they really look to all of the models with all of the different expertise that's built in, different kind of data and huge amounts of uncertainty to give them the most robust situational awareness possible. So this is a screenshot from the CDC's forecasting page that includes our model and many other models. This sort of ensemble approach has also been embraced by the press. The forecasts appear in ensembles on 538, and we're on the front page of the New York Times yesterday as well. And finally, the last thing I want to focus on is our ongoing efforts on a daily basis to support situational awareness and planning, particularly with the city of Austin, but also, at the national level, planning for in terms of what might happen in the next few weeks and what kinds of data-driven, evidence-based decisions we can make in days and weeks ahead to ensure that we protect our populations, protect our vulnerable populations, ensure that we don't exceed local hospital capacity while not imposing just an unmanageable economic and societal burden in our communities. So I'm going to run you through a few quick slides just to give you a sense of how we're thinking about it. So what might happen? So this is going to be a hypothetical if we just did nothing. We just basically let this virus spread come what may, as of May 1st, at the point in time when we started relaxing social distancing measures. So if policies are relaxed and we assume that people are still being somewhat cautious, but not super cautious, so they're starting to go out and maybe they're washing their hands, but they're still allowing for some transmission. So we imagine that transmission rebounds to half of baseline. We sort of go back to halfway between where we were during lockdowns and where we were at the beginning of March before we did anything. This is what we might see, and this is a projection for the city of Austin, but it would look very similar in other cities. So that first gray swath is the period of time when Austin was under the stay home work safe order, which corresponds to when many Texas cities were. You see a little blip at the bottom, that's our current kind of hospital curve. And if we really relax to where transmission rebounds to about half of baseline, we would expect to see an unmanageable surge in hospitalization. So the red line is heads in beds, hospitalizations in Austin. The black line is projected deaths. That red horizontal line is a very optimistic estimate for surge capacity in Austin. This means we're basically tripling the current bed capacity of hospitals in Austin. We would see that by mid-June, we would have hospitalizations that far exceed our optimistic capacity. And in fact, this death projection is not accounting for any of the excess death that would occur among COVID patients and among other hospital patients if and when we exceed that line. This is not a situation that I think any decision maker would allow their community to run into. So somebody would put the foot, everybody agrees that we should put our foot on the brake before that happens. So how can we navigate this? How can we avoid what a very plausible scenario in which Austin and other cities in Texas end up looking like what we saw in New York and Italy? And in this scenario, this is just along the bottoms, schools potentially could be open if we're going back to life as normal. Okay, so what we've been working on is a framework for thinking about how can we monitor data on a daily basis, data we can actually see, like numbers of hospitalizations, numbers of cases, and figure out when the right moment is, the right day is to trigger a different action, to enact maybe slightly more strict measures or vastly more strict measures, depending on what the situation on the ground is. And we've been developing this framework in general, but also been applying it in real time to helping Austin think through its planning. So here's the way we're approaching it in the model I'm going to show you right now. What is the shortest lockdown required to prevent an overwhelming surge? So in other words, when should we trigger to, we're going to imagine there's two states that our population can be in, either we're relaxed or we're in a strict lockdown. And what is the best trigger to use so that we minimize the amount of days we're in that lockdown, but ensure that we never exceed our local hospital capacity? And when we do that, in this particular scenario, and this is just a scenario, this is not a specific projection, so take the numbers with a grain of salt, but in a plausible scenario for Austin, we derive that the best trigger is that as soon as there are 80 new heads in beds, 80 new cases hospitalized in the city, we should enact a lockdown, and then we will release that lockdown when new admissions falls back below a level. And what we project under that policy is that come mid-June, we will have to lock down again to avoid that surge I showed you on the last slide. That lockdown would have to last around 3 months. And maybe in this scenario, we could actually open schools about a month after about a month after we were originally planning to in Austin. And we see that there is a third wave that happens, but in this case, because our population is approaching herd immunity, that third wave would be self-limiting and not exceed hospital capacity without an additional strict measure. So this is just the framework that we're using to think about it. In this case, again, there would be quite a few deaths. So this approach is not minimizing deaths. It's just ensuring that we do not exceed hospital capacity. So how do we actually implement this? Well, if we were going to actually implement these kinds of policies, we need to have really good daily situational awareness. So we are hard at work trying to come up with really as sophisticated, as good models as possible using the best available data on the ground to estimate how quickly this virus is spreading on a daily basis as people change their behavior, as policies change. And so this is just an example of output from our current model. So this is for Austin. We are on a daily basis estimating what is the reproduction number. So how fast is it spreading in our city? What's the rate of hospital admissions in our city with projections going out in yellow, and what is the current deaths in the city with projections going out just a few weeks. And to implement that kind of a strategy, we need to be monitoring, understanding the changing situation on the ground, and be taking steps to slow transmission before it gets too late. Because as you can see in those exponential curves, that if you wait until things look threatening in your hospitals, you've waited too long. So with that, and I'll just say for Austin, we estimate that the reproduction number before we did anything was probably above 4. At the best point when we were most strictly social distancing, our reproduction number was significantly below 1. And right now we're precariously close to a reproduction number of 1, which is that threshold between a mitigated epidemic that will not grow exponentially and an unmitigated epidemic, which will slowly or more quickly eventually grow exponentially. So with that, I'll just want to acknowledge that this is the result of the hard work of many people who have joined our consortium that we stood up about two months ago. It includes people across disciplines with, including many people from engineering, computer science, Dell Medical School, but also people from other institutions across the United States and even internationally who are contributing to kind of an all hands on deck, bring your skills, bring your expertise to the table to improve the model so we can understand what's going on and inform, bring whatever data and science we can to the decision makers who have the really hard job of protecting our populations. So thank you.
Well, thank you so much. It was a great overview. And we have, this is such a rich discussion. We could easily make this a whole afternoon of discussion, but unfortunately that's not the way we're going to proceed today. We have only an hour in total. So I thought we get to some of the questions that have been put forward by our audience, and I'm going to try to generalize them a bit rather than some of the specific questions, and ask each of you if you could give your response. There's a question from Vernita Gordon who asks, is there a way of thinking about what a modified lockdown would look like instead of the binary on or off state in this model? For example, schools and workplaces operating at reduced capacity, staggered schedules, social contact allowed with 1 or 2 households rather than none. I would just modify that a little bit also by specifically asking what we need to do to open up businesses and focus especially on the workplace for both how to make them safe and what additional steps need to be put in. So I'll ask Dr. Fischer first, and then Dr. Ancel Meyers.
Sure, thank you. Fantastic question. I think a lot of us were reeling in that initial days of stay home and work safe. So I think first we need to remember the transmission route. So this is primarily, we think, respiratory, but also through contact. There may be some aerosolization. So education of individuals is going to be really important in mitigating anything that we do. And so there was a large study that came out from RTI that suggested that despite the fact that we are all told to wear masks, and wash our hands and practice safe hygiene, most people don't understand why that's the case and what benefit that has. So there's still a lot of opportunities for public health messaging. And so those will inform things like, how are we safely able to be in a restaurant or a store with individuals? That will inform how business owners approach distancing their employees and sanitizing the facilities. So all of these are going to be really important. And fortunately, we've learned a lot through this first lockdown. So when we first sort of shut things down, we didn't know any other way. It was an aggressive measure, and it was to prevent individuals from coming into contact with each other. So preventing that transmission. Without a cure and without a vaccine, that remains our strongest tool. So what we've now learned is we have some ways that we can still operate an economy and consumer-based society, being creative and exercising caution. And I think that something that has come out of that really traumatic event are some creative ways that we can do that. Dr. Meyers?
Thank you. That's a really excellent question, Dr. Gordon. And had I had more time, I would walk you through some more details of the analysis. But what you asked is exactly what we're doing today. So if you're in Austin, you may know that, and I think this is happening in other cities too, that Austin just yesterday released a 4-stage system, alert system, from blue to red to purple, or I forget what the current color code is, but that sort of is meant to communicate different levels of risk in the community that corresponds to different degrees of community transmission. And what we're doing right now with this approach is trying to come up with triggers for different levels of restricting work and restricting other kinds of public interactions. And so it is possible, and that is what we're in the middle of doing right now. The challenge is that this is so unprecedented, right? So there's no historical data with which we can estimate if people go to work with 25% occupancy, or we go to restaurants with 25% occupancy, what does that do to the transmission of disease? Or if 10% of our population is not adherent, what does that do to the transmission rate of the disease? And so we are doing our best to build models that are learning as we go. So if you think about like the Austin levels from green to most alarming, we can say, okay, the most alarming in terms of like completely unmitigated transmission, we may be able to estimate what that looks like by looking at behavior and COVID-19 data from prior to March 15th. If we want to look at what like sort of the most mitigated lockdown looks like, we can fit our models or estimate what was happening between March 24th, which is the stay-at-home order, until about April 20th, when behavior started to rebound. And then there's sort of like this intermediate period between April 20th and May 1st, where people were starting to relax, but the policy hadn't been put in place to relax. And now, from now, and depending on what the governor does, if we enter a new phase on May 18th, we have another period where we can kind of look at the data and try to estimate what that level of social distancing does to transmission and put that in. But for now, we have to just sort of make educated guesses and do a lot of sensitivity analysis around the assumptions we're making about how different measures might impact transmission.
But if I could ask, just to follow up on that a little bit, given that the state of testing is so modest, what kind of data are you actually following to look for those triggers where you could create an alert system? I mean, how can you have a robust alert system if you don't have the testing data to feed into it?
Yeah, that's a great question. So we don't use the testing data because it is so confounded by testing effort and testing priorities. So it's really hard to look at numbers of confirmed cases and for anything reliable about where it's spreading and how quickly it's spreading. So at this point, we cannot use that data reliably. What we look at specifically, where we believe we have the strongest signal and the best ability to do sort of real-time situational awareness, is in daily hospital admissions. And we have, through an unprecedented collaboration in Austin between the decision makers, the leaders of the city, all of the hospital systems in the metro area, and the researchers at UT, we have been able to get comprehensive daily numbers of admissions. And up till now, I mean, actually, if you'd asked me this yesterday, I would have said, this is great data. It's just about the most reliable data you could possibly have. It's better than total number of hospitalizations, because the problem with total number of hospitalizations is some people are hospitalized for a very short period of time, some for longer, and we're actually seeing that the duration of hospital stays is changing, perhaps partly because long-term residential care facilities like nursing homes are less willing now to take patients back, and so they're ending up in hospitals longer. So it's very hard to interpret total number of people in hospital, but the new admissions gives us kind of a good signal of how it's a 2-week lagged signal, but a good signal of how quickly it was spreading about 2 weeks ago. However, what I learned this morning in Austin is that the criteria for testing in hospitals is changing. So up until recently, people were tested in hospitals with COVID-19 if they had symptoms that related to COVID-19. And so we imagine that most people who were hospitalized for COVID-19 were actually the reason were hospitalized and were diagnosed with COVID-19 were hospitalized because they had COVID-19. Now they're testing all patients, which means that if patients come to the hospital for another complaint, another reason, and they happen to be mildly symptomatic or asymptomatically infected with COVID-19, they're going to be caught up in the admission data. And so we're going to have the harder job of kind of now teasing out which proportion of those new hospital admissions are because people are actually hospitalized because of complications due to COVID-19, and what proportion are just coincidentally infected by COVID-19.
But if I could just follow up with both Rebecca and Lauren, which is that if indeed there is that lag of whether, the incubation period is typically about a week, so hospitalizations, could be a week or 2 weeks behind, and how serious that can be by not being on top of things within a week or 2 weeks. Would both of you want to offer anything about syndromic surveillance technologies that are out there, and is that something that we should be actively promoting, and what are some of the different systems looking like, and what is the opportunity to bring in TAMEST and our state? This is when in my opening remarks, I talked about our state's engineering horsepower to really create both a system of syndromic surveillance or even contact tracing that would get our arms around this faster than simply waiting for hospital admissions or death. So I'll ask Dr. Fischer first and Dr. Meyers.
Sure. I think the biggest challenge with syndromic surveillance with this disease is the great variety of presentations. We know from the early data, and it's held from the very first reports out of China, less than half initially present with fever, less than half initially present with cough, although they may develop it during the course of their illness. By the time symptoms have begun at the end of that incubation period, they're already infectious spreaders. So the virologists, the most current information, I believe, the virologists think that that incubation period may be 5 to 7 days. For most people, infectious period starting as early as the second day after infection, and actually a high viral content, so quite a lot of spreading during that first time, and then really in that first week of symptoms, so out in the community. So contact tracing, I think, is going to be the most important tool, which of course involves testing, and we are really struggling in our local level with testing and sort of changing the initial paradigm where we thought we want to test individuals with fever and cough. We only want to test individuals that are at risk of severe fatal outcomes. When our understanding of disease is changing. So when we're sending, for example, with contacts tracing, we're sending contacts to be tested. They may be asymptomatic or may have mild disease, and come to find out, it seems that very few individuals are truly asymptomatic. They just attribute their signs to other things such as seasonal allergies or a common cold, or simply fatigue and staying up too late the night before. So I think that with respect to syndromic surveillance, certainly it's a useful tool, but it's going to miss a lot of cases up to 50%. We've heard in the older individuals, individuals with dementia, their most common sign is increased dementia or increased manifestations of that. In children, it may be rash on the feet. So we just have this disease is just really troubling clinicians and diagnosticians because of that. So I think that diagnostic testing, tracking the virus where it is, and this is really labor intensive and it requires a lot of tests. So if there is a way that we can expand that and bring that and make it accessible to everyone, then I think that's going to be our most valuable tool at this stage. I don't think fever screening is the most useful tool. I think that's also labor intensive without a lot of benefit, but certainly we talk about this a lot, and at Texas A&M as well as in the Texas Medical Center and the University of Texas, we talk about students coming back to live in dormitories, and how do we do that? How do we do syndromic surveillance and monitor those individuals that are suffering mostly a milder form of the disease, but have high social contact and remain a risk to the community of transmitting that virus around. So I don't know the answer to your question, Peter, but it's certainly challenging. And I think putting some brains together is certainly necessary in this situation.
Dr. Meyers?
Yeah, so I think Dr. Fischer is right on. It's an enormous challenge. And I think the short answer is yes, bring the great minds, the great engineers to tackle this challenge. I mean, we don't, and it's kind of really in a two-way information flow challenge. Like, we would like to have better real-time situational awareness of who's infected and how fast it's spreading. And if we can come up with a next generation way to do that, where, you know, people are buy-in and are willing to share whatever information via their cell phones or whatever, that will help us get better situational awareness. But there's also kind of the reverse flow of information to people, to encourage them to stay home if they have a rash on their foot, and to let the people know that they've come in contact with. So kind of, you know, distributed contact tracing and voluntarily erring on the side of caution to protect family members, to protect their neighbors, their community members, particularly people who are high risk, could actually go a long way, particularly at a time when we are so under-equipped to do testing, contact tracing, and isolation.
That's great. We've had a couple of questions regarding herd immunity. You know, if anyone who watches the cable news has seen Mike Osterholm on a few times, and he tends to give pretty apocalyptic predictions, saying that 60 to 70% herd immunity is inevitable, and that's scary for a lot of Americans, and including old guys like me, right, who would be at higher risk because of age. What about herd immunity in terms of where you see this heading for the state of Texas? Rebecca, any thoughts? Lauren?
I suspect this remains a large unknown at this stage. Somebody else asked about attack rate, and this kind of goes into the same question. If we don't know exactly how many people are infected. We don't know what proportion of the population really has been affected. So we're talking about our attack rates being, you know, 0.2% of our population in Texas. It doesn't sound like a lot, although it's a lot, and those are just the detected cases. So without any way to expand and really liberally test individuals, including those without signs yet, or may not develop signs, it's going to be really hard to gauge this. So the idea is that herd immunity, the more individuals who recover from the disease are immune somehow. So we don't understand immunity with this disease yet. Most immunologists suggest that we probably are going to be immune for some period of time, but maybe by next season we would be susceptible again to an infection by the same or related virus. So there just simply isn't an answer to this question. Of course, what we do want to see is people recover, and we do want to see immunity, and we do want to see that transmission rate be blocked by immunity. But yeah, I don't have a fantastic answer for that one. Lauren, maybe you could shed some light.
Sure. So I mean, I think what Dr. Fischer said is absolutely right. Like, so we don't actually know if people are immunized following infection, but under the optimistic assumption that after you are infected, you are at least temporarily immune to subsequent infection, or if you do get infected again, it's going to be mild, you won't be as contagious. Like, under that optimistic assumption, unfortunately, the models are pretty consistent, and our experience with influenza and other respiratory viruses all point to the same thing, which is that this thing spreads quickly, it spreads silently, and it really is going to have to, probably over 50% of our population, if not more, will have to be infected with, in the absence of a vaccine, will have to be infected before this thing starts to dissipate on its own. And so, in Texas, we probably have seen less than 2% of people infected, even accounting for the asymptomatic infections. It's very likely that it's very likely that very few people have been infected so far in Texas. So we have this very vulnerable population, and depending on the extent to which we relax, we will see second or possibly third waves. And I mean, unfortunately, there is no silver bullet until we get a vaccine, right? And people who are high risk, who are over 65, who have underlying conditions, it may be that those populations really need to be sheltering for the foreseeable future, even as the rest of the population relaxes. Now, I mean, the only scenario in which there's sort of two scenarios in which that would not be the recommendation for the vulnerable populations. One is if this thing gets out of hand and we actually have a huge, basically a single wave pandemic that runs its course and is over in the next few months, that sort of catastrophic graph I showed you earlier, in which case nobody wants that, but we might actually be on the other side in a very bad way of this in a short amount of time. That's probably not going to happen. The other way in which people can feel a little more comfortable, even if they're vulnerable, is if we really are repressing transmission. I mean, this would be a scenario where we actually had waited until there was almost no virus in our communities to start to relax things. We actually had testing, tracing, and isolation up and running, so we could quickly contain emerging clusters. People were taking precautions, and then there's a scenario where you just keep community transmission to a minimum for the foreseeable future. But it doesn't look like that's going to happen either. So we're probably going to be in the situation where there's going to be persistent community transmission, a non-negligible force of infection, so that if somebody is vulnerable, they probably should be protecting themselves. And unless we're in one of those two situations, or we get a vaccine, that's probably going to be the scenario for the, for maybe, a year to come.
Thank you. We have a couple of questions around different scenarios, models in different parts of the world. And whoever wants to answer this, one question is, what do you make of the 10-4 cycle model for reopening proposed by the Weitzman group, led by Uri Alon and Aaron Yashiv? That was an anonymous question. I'm not actually familiar with that, so I'll leave it to one of you. And then we get at getting asked about the Swedish model and what they're doing. Curious, and then we'll wrap up.
Lauren, I'm going to punt that one to you. I'm not familiar with that model. Maybe you are.
Yeah. Well, I actually haven't read the original paper, but I did read their editorial in the New York Times that just sort of described it in broad brush strokes. And the idea is that, I may be butchering this, but that if you time it right and you kind of rotate people being able to work for a few days and then off for a few days, then work for a few days, so that they're not in one place long enough to allow sort of a full chain of transmission, you might be able to kind of limit spread. So it's a sort of block rotation idea. And there have been a number of different groups, including people at the University of Texas Austin, who've been thinking about, are there sort of creative ways to rotate people in and out in a way that we really prevent kind of long range connections that can lead to rapid spread across a community. And I mean, in theory, there may be something there, but you have to keep in mind that, in our very heterogeneous, cities, there are people who maybe can afford and are informed enough to comply with block rotation. And then there are parts of our communities that may not have that information, may not be able to afford to do that. Et cetera. So I think, in theory, it may work. In practice, I think there's a huge question mark. And then with respect to Sweden, it seems like either the jury's still out or really the jury's in, and this was not as successful as people had originally hoped, with the kind of more alarming numbers, mortality rates that are now seem to be the case, particularly in older individuals who live in long-term care facilities. So I don't know. And again, even if that was a good model, could you actually implement something similar in our very heterogeneous and where heterogeneous cities where there's a lot of disparities, right? Just even from one side of town to the other.
And I do have one comment just about our modeling in general, and Lauren, maybe you'll agree with this, but the models are great at providing us sort of mathematical and biologic possibilities. Something that I think we struggle with in modeling with this disease, and especially evidenced by recent data, is it's so clustered, it's so pocketed. And we're seeing here in Texas in our local levels, sort of what has been iterated by individuals, clinicians, and epidemiologists in New York, where we had, of course, the importation, travel-related cases, and then some community unknown source spread, and then really went to big clusters. So getting into the long-term care facilities, occupations, the packing plants, the processing plants. And what we're seeing in some places here in Texas is sort of infiltration into the households, reflecting clusters that are household-based. And some of these households are large households with low socio-demographic indicators. And so multi-generational families living in someplace sharing facilities, bathrooms and beds and such. And I think this presents a major challenge to the models because we are just seeing these pockets, and that's kind of tough to predict, I think, at this stage, since we're still sort of seeing that situation evolve.
Great. Well, thank you very much. Terrence, I'll let you have sort of the last word and your thoughts.
Thanks very much, Dr. Hotez, and thank you, Dr. Fischer and Dr. Meyers, for your sharing the science with us today. That's fascinating and frankly, quite worrisome that don't see a lot of light at the end of the tunnel, but I'm really grateful for your work in helping us understand what's happening, and for the work of all of our researchers in Texas, really looking to the science to provide us a path forward here. So TAMEST is grateful for all of you and your work. And we will have the video of this presentation up on our website. You'll receive a follow-up email for the participants today that will point you to that. And we'll also ask the presenters if we might be able to post their slide presentations on our website as well. We are hoping to do some more of these sessions in the future. And we're starting to plan our next session, which will be on mental and behavioral health and some of the impacts of the pandemic on that in Texas particularly, but we'll obviously have some broader implications. So stay tuned. We are putting that session together, and we'll hope to have it set up in a couple of weeks. We'll just like to once again thank all of the speakers for joining us today, and for taking the time to share the science with us. Thank you again.